All right. So thank you everyone for joining us today. This is the National Telehealth Webinar Series, and we are going to be talking about your answers to your most burning telehealth questions. As always, this Telehealth Resource Center webinar series is presented by the National Consortium of Telehealth Resource Centers. And we have several panelists today from different resource centers around the country to answer your questions. And at this point, I'm going to hand it over to Andrew.
Thank you, Becky, and thank you so much for organizing all of our monthly webinar series. We really appreciate that. And thank you everybody for joining us today. So as Becky mentioned, we received a ton of questions through the registration process for this webinar. Really excited to see those, some really interesting questions. Unfortunately, we certainly can't get to all 108 questions in an hour, but we've split up into 3 sections that we're going to try and address some of the broad questions initially. We certainly welcome you to submit any questions through the Q&A box. We will try and answer as many of those as we can live if we have time. We might try and answer some of those through text, texting back to you through the Q&A box. But we have a really great panel today. To start off, we have Lloyd Sermons, the director of the Southeast Telehealth Resource Center, and Donna Johnston, the program manager for the Telehealth Technology Assessment Center. We also have Doris Barta, the director of the Telehealth Technology Assessment Resource Center, and also joins the advisory board for the Northwest Regional Telehealth Resource Center. Sarah Rhodes is with the Southeast Telehealth Resource Center. And of course, Becky Sanders, who you've all met already, is with the Upper Midwest Telehealth Resource Center. And I'm Andrew Solomon. I'm the project manager for the Northeast Telehealth Resource Center. So to start off, we'd like to tackle some of the technology questions. Certainly telehealth isn't possible without the technology. Often we hear that maybe technology is the last thing that's addressed when starting a program. Sometimes it's the easiest step, but certainly not always. So one of the questions I think was really interesting, and I'd like to turn this one over to Lloyd to begin. Someone asked, have organizations successfully achieved interoperability between telehealth platforms, EHRs, health information exchanges? So Lloyd, could you talk to us a little bit about this whole interoperability issue?
Yeah, thanks Andrew and Becky and all of you guys who are participating. Of course, interoperability, that's one of the questions that always seems to come up when we're speaking on telemedicine and telehealth, and it's always, of course, in today's culture that we live in with health information exchange, it's always an interesting topic. So it's always that one question that seems to pop up. Yes, there are organizations who have reached interoperability. I think, 2 words that come to mind when I talk about interoperability, and we talked a little bit about this the other day, Andrew and Donna, one of those being resources. And so, when the organizations that I've had the opportunity to work with, who typically have met and gotten to a point you could consider them being interoperable, they're typically going to be the larger healthcare systems who have plenty of resources at their fingertips. And when I say resources, you can break that down into 2 categories. I think money is one of those resources that to reach interoperability you will need or people, I guess you could say. So we live in a world where ideally with health information exchange, the idea being, hey, I should be able to, take my medical record and it should be accessible no matter where I'm at, where I go. The issue is there's so many electronic medical records out there today, and it seems like everywhere you go, everyone's using a different one. So in order to make those it's not a matter of will they communicate with each other, it's having to make those communicate with each other, and that's where those resources come into play. And so, yes, it's doable, and And in a perfect world, they should just be able to communicate no matter which one you have. But you do have to have those resources to actually make that happen. So I know Donna had some thoughts on that and some comments as well. So Donna, I mean, if you want to elaborate a little bit more and expand, feel free to go ahead. So.
Yeah, I've seen different levels of interoperability. Some interfaces that appear seamless. They transfer the case, and then the software goes back and deletes the images from the original system, and the physician isn't required to do much else than click a button. Others are integrated, but there's a clunky 12-step workflow that the human has to do, which leads to the possibility of error. So interoperability is definitely possible. It tends to cost a lot of money. And I work with a team of programmers. Well, I sit near a team of programmers, I should say, and we still struggle with making our tribal health system electronic health records talk to each other and communicate seamlessly.
Yeah, and I know one of the things that I think we're seeing now with some of your larger electronic medical records is the fact that they're now embedding video applications into their electronic health record to try to, I guess you could say, eliminate having to run so many different platforms, or have a video application running over here and have to have a your electronic medical record running somewhere else. So we are seeing that a little bit more and more now as well. So
there's definitely a lot going on with that interoperability issue. One of the other questions we received in registration, and Donna, I'll ask you to answer this one first if you don't mind. What are some of the important security and privacy issues that folks should be thinking about when they're integrating some of these technologies?
Well, the HIPAA law was passed 20 years ago, so I don't think that there are no medical professionals that aren't familiar with patient data security. When you're looking at transmitting electronic health records, you're just adding a different set of locks and keys. There's access control. You provide users logins and passwords so that only certain people can view the records. There's actually physical security. You don't want people to be able to look over your shoulder at a patient's medical record. And then there's encryption. You can encrypt the data while it's at rest. You can encrypt the network that the data travels on, and you can send encrypted data over an encrypted network. And only the people with that encryption key can open and view the data. So another consideration is data storage. Is that a secured system, or are your vendors that are providing the storage, are they going to mine the data and sell that to researchers or universities or insurance companies? There's a lot of considerations when you talk about patient privacy. I think it's network security is something that IT professionals and large corporations have been dealing with for years. So if you have a robust IT department, a lot of the systems that are already in place will lend themselves well to telemedicine.
And Lloyd, would you have anything to add?
Yeah, I mean, I think, she kind of hit the nail on the head. I think one of the things that we find that we have to work with folks a good bit on doesn't tend to, most of your applications are good about, making sure there's a certain level of encryption. I think one of the things we deal with most often is just simple things like, how do you set up your room? And Donna kind of alluded to that. You have to take into consideration some of those straightforward standard HIPAA rules and regulations, so that when that telemedicine unit's set up in that room, you have to take some security measures in setting up that room, and just making sure that there are some safeguards in place in regards to the patient who's going to be in that room on that telemedicine equipment. And so sometimes those things are the things that we have to really work with folks on more often. but most people are at this point, healthcare professionals are familiar enough with HIPAA, but sometimes you just have to help remind folks in certain areas.
So I see in the Q&A we got a question about the timeline for program development, and we'll dig a little bit more into that. But at some point, folks have to decide what vendor, what technology they want to go with, and what's the best fit for them. So maybe Donna first, do you have any thoughts on sort of tips to selecting a vendor?
Absolutely. Just like when you want to pick a certain piece of equipment to work in your medical practice, you want to make a list of requirements. What do I need this vendor to provide? Am I a small clinic and I need that vendor to be my backbone support in addition to the initial sale and setup? Or do I have a really robust health system IT staff and I just need the devices and we'll take it from there and run? Do I want to have a local presence so that someone can come to my office, or am I more comfortable with a larger organization that provides an online 24/7 support system? There's so many different considerations, and it really depends on the user needs. But what I would mainly caution is to watch out for vendor hype. I've been to a lot of these conventions, and the vendors are very excited about their products. The literature says it solves a host of problems. A lot of times when we bring it into our lab, though, we find that it's clunky and maybe not as good as the salespeople thought it was. So I would definitely ask other members of your professional circle which vendors they've successfully used and what they might recommend.
Hey, Donna, somebody commented that they're having a hard time hearing you. Could you speak up a little bit?
Sure. I'll scoot in, I guess.
Well, Andrew, I think along those lines too, and I'll back up even a little bit further ahead of what Donna was saying, and we see this a lot, but I think the big thing is know what you want your program to do. Because a lot of times, and we have great relationships with vendors, but a lot of times, a vendor, they want us, they're in business to sell equipment. It's what they're in business to do. That's their goal. So I think knowing what you want your program to do, and then when you're looking at these vendors, have a plan. And then when you talk to the vendors, like what Donna was saying, look for the vendor that fits your need. Or what services are they going to offer outside of, say, just selling you equipment? And we get called a lot of times to where we've had folks come in and they say, hey, we've bought all this equipment, now we don't know what to do with it. So I think it's very important, when you're talking to that vendor, if you know what you're wanting to accomplish with your telemedicine program, then hopefully you can choose a vendor who has some interest in helping you do and accomplish what you want to accomplish. And then that way it's not just all about the equipment, because now, in today's society, technology has advanced really to the point to where you can do things today, and I don't like to use the term cheap, but you can do telemedicine programs now at a lot less costly venture than what it used to cost. The second thing, though, is another thing that we see a good bit, and I always use the term, don't box yourself in. Don't go out and spend $200,000 getting equipment that, when you sit down and you go, oh, well, you know what, man, it would be nice to be able to do this as well. And then you have to go back and spend another $100,000. So kind of think ahead as well. Okay, we want to start out doing telestroke, but hey, you know what, in 6 to 12 months, we may want to do some primary care. So, try to keep those things in mind. So when you're selecting a vendor, select someone who will sit down and actually spend some time working and looking at what it is you want to accomplish and how you can get there and how long it might take you to get there. Because I'm a firm believer that if they'll sit down and spend a little bit of time with you, they typically have an interest in your program and not just offloading some equipment to you and then moving on. So.
And I'd also make it a team effort when you're selecting a vendor. I would bring medical professionals and maybe an IT person and someone from finance so we can talk budget. Just get the entire team in your organization involved in selecting the vendor because they may have a point of view that someone else doesn't. I know in the lab, Garrett and I aren't medical professionals, but we play with medical devices and then invite the physicians over to play with them. And they're saying, you're not supposed to hold it this way. This is an awkward design. I can't use this with one hand. And that's something that we might not consider because we're not looking at patients all day. So it really should be a team effort to select the vendor.
Yeah, and Donna brings up a real good point. I can tell you, I have been on site delivering equipment on a number of occasions, and IT goes, "What is this? Who are you, and what is this?" And that's usually an interesting conversation. So yeah, please get IT involved on the front end.
Mm-hmm. Perfect. Well, thank you both. We did get a couple of questions, technology questions for the Q&A. I think we'll hold on to those just for now so we can make some transitions and stay on time. Lloyd and Donna, if you'd like to try and answer some of those through text, please feel welcome to. I think now let's spend a little time talking about policy and why we've been talking about technology, and certainly technology is a critical piece to make the connection. Mario Gutierrez, the director of the Center for Connected Health Policy, our National Policy Resource Center, has joined us. And Mario, I think it's probably a good time to talk a little bit about policy. It's such a hot topic, so much is happening. I think probably one of the most common questions where the Northeast covers, where one of our insurers has decided to reimburse for telemedicine services at 50% of the rate for in-person. So I wonder if you could talk a little bit about telehealth reimbursement, the parity laws, and all that's happening in that space.
Sure, thank you. And it's a great opportunity to really share all of our resources here with the Telehealth Resource Centers. The thing to keep in mind when it comes to policy is that CMS at the federal government determines specifically what the federal government can do through whether it's Medicare, the VA, the Defense Department, and they each have their own policies related to that. So for example, with Medicare, it's very stringent, very limited, only limited to live video, to very strictly defined rural areas. So they have a long ways to go to catch up with where telehealth is today. Fortunately, the states are given considerable discretion to define for themselves how they determine their own telehealth policies when it comes to their Medicaid programs, as well as any particular laws related to governing private payers. And over the course of the last 5 years, we've seen much more interest on the part of states, particularly as we move more into value-based delivery systems. As you mentioned, one of the things that we do is a thorough analysis of every state, and on our website at HPCA, you can click on your state and it'll give you what your laws, regulations, and policies are according to 10 different categories, including reimbursement, type of service, who can do it, and so on. What's been concerning to us, and I think more perplexing, is the fact that despite the fact that states have considerable discretion, we've seen very little development in terms of a more comprehensive approach to modernizing the laws related to telehealth. Many states still define it only as telemedicine, despite the fact that it can apply to any number of health disciplines. For example, even though 47 states now have a definition for and reimbursement for live video, only 9 states reimburse for for store and forward, which is a much more efficient way of delivering care, particularly in teledermatology and ophthalmology. And 16 states reimburse for remote patient monitoring, but the majority of those are done through special programs under their Department of Aging or Office of Aging. So we have a long ways to go when it comes to being much more comprehensive in our approach to reimbursement. The National Conference on State Legislators is a very good resource. I think states are looking for ways to figure out for themselves how to move forward. We certainly provide technical assistance, but NCSL has just put out a very good policy paper in that regard and can provide assistance. When it comes to the issue of parity, this is an area that's very much misunderstood. Even though we have over 33 jurisdictions in the country that now have some form of parity law, when you really read them carefully, they're not always about parity of payment. Some of them only provide parity for the provision of services within the benefit plan of a particular payer, but doesn't necessarily guarantee or insist that that payer reimburse equally for the telehealth service as opposed to the in-person service. So in the case you were describing with Excelis, the company in New York, where New York just passed the parity law, they failed to include the provision related to parity of payment. And in this case, the insurer decided, well, we're just only going to pay for 50% of the reimbursement, which again puts telehealth in a different, as if it was a different form of healthcare. And our whole goal here is telehealth is a modality. We shouldn't even use the tele anymore. It's about a different way of delivering healthcare, but it strengthens the way we do our healthcare and should be reimbursed on an equal basis.
Yes, thank you. So another one of the policy questions that was sent in before the webinar was related to licensure. I think this is probably a pretty common question we get from providers who are looking to provide telehealth services themselves. So could you talk a little bit about what is required for licensure and then some of the compacts that have been floating around?
Sure. First and foremost, telehealth is a way of delivering health care. So it's not a separate license. Some people think that you need a separate license to deliver telehealth. If you have a medical license in good standing, you can use that. You can provide telehealth in your state, or if you're a dentist or whatever your state allows in terms of telehealth. One of the real challenges that we face is that telehealth really has given us the ability to cross across the country, you know, from not just from state to state, but from border to border for specialists and providers who are able to provide care where there is a shortage. However, we're limited in most states by the requirements of their medical boards, in this case speaking about medicine, that will only allow you to practice medicine in the state in which you're in. And very few states actually allow for physicians who are licensed in other states to actually provide care, only on a very limited basis in those cases. So the pressure has been put on the medical boards, and so the Federation of Medical Boards, the National Federation, has developed language for the creation of what's called a compact, so that it facilitates the process for a physician who is licensed in one state to be able to receive a license in another state. Different than the nursing compact, which allows nurses to practice in other states when there is under their nursing compact. This only facilitates the process for the application. It is a step forward, and I think it is a recognition that physicians, particularly in areas where you have contiguous states, like in the Midwest, that it allows for those physicians to practice in other states. So as of now, 17 states have passed the specific language to join that compact. They have formed a commission. They're in the process of defining for themselves now in that commission how that compact is going to work, and it's still months away. And we also see that other states have introduced legislation. So I think that's the key. But you know, in summary, it's still not possible for physicians to practice in other states unless that medical board allows them to do it.
Thank you. And just taking a quick step back to the parity laws, I see Courtney sent a question that we might be able to answer quick here live. Is the originating site fee included in most parity laws?
To my knowledge, it is not. That is specific to the state's requirement on whether or not they have an originating fee. And so if they do, then to that extent, if they're practicing in that state, then whatever that law requires in terms of originating fee will be allowed.
And I look to the whole panel. I think, if I understand right, Mario, it seems like it's really the Medicare and the Medicaid programs that are doing the originating site fee and less common for the private payers?
Correct, yes.
So then I guess just one last question before we kind of transition to our next theme. You mentioned the medical boards, and regulations seem to be a really important component of policy. There's a lot of activity in Texas. There's been a lot of news coverage on what's happening in Texas. Can you talk a little bit about telehealth regulation versus some of the other legislation?
Excellent question. I think that even in those states where we have more progressive, comprehensive legislation regarding policies to allow for the reimbursement of telehealth in those different categories, ultimately it's up to the state Medicaid program to determine the codes and regulations specific to that, and many times they don't go as far as the legislation. And more we're seeing the particular boards, whether it's as I described now with medicine, but also with dentistry, optometry, physical therapy, other forms of licensing boards, will for themselves develop their own regulations and specific requirements to receive a license and to practice using telehealth. So it's important to keep a careful eye on that. And as part of our work, we try to track across the country what licensing boards are doing to ensure that they have language that is consistent with what the law says, as opposed to making it more restrictive.
Thank you. And one last question, Mario, that you might like to answer that just came in live from James. Does the VA have a stance on medicine and treatment through video for reimbursement for care to veterans?
Well, the VA has been one of the more, I think, advanced users of telehealth. They don't have to comply with the licensing requirement as long as they're practicing within a VA facility. And so many of the laws within the state don't apply because it is a federal program. And so I think you see much more of use of store and forward, use of remote monitoring, live video to be able to, particularly in the area of behavioral health, has been one of the real advances that the VA has been able to accomplish.
And I think I heard for fiscal year 2017, they included $1.2 billion in their budget. And then in 2015, they saw almost 700,000 veterans through telehealth.
Yeah, they are. I mean, they're the standard bearer. So if we could do it in the VA, and if we can do it in the Department of Defense, we should be able to do it in our Medicare programs in our states at the same level. And so we have a ways to go to have standard parity with other forms of services within the federal government. That's the irony here.
All right, thank you, Mario. So let's transition to sort of what we'll call our operational panel. We have Doris, Sarah, and Becky. And we know technology is just the start. Policy is a critical factor. This question has come up a couple of times. How long does it start to start a telehealth program? So Doris, first, what do you think? What are some of the other challenges that folks are facing? How can we address those? And what are some of those critical factors to getting started?
Thank you, Andrew. I think, one of the very first things you need to do, and it's been touched on by technology really and by policy, is what is it that you truly want to do with your telehealth program? And then you need to go forward from there. So one of the first things you need to do is find out from the leadership within your organization what their priorities are for a telehealth program. Because if you don't have a strong backing of your leadership within your organization, it's going to be very difficult to establish a telemedicine program. There are things to consider with regards to your program that depends on what kind of an organization you are. If you're a hospital that's a fully integrated medical system where the physicians are employed by your organization, and you have affiliate organizations out in the region, in the rural areas, it's going to be a lot easier for you to establish a telemedicine program because your leadership can create an atmosphere where telehealth is expected as part of your outreach services to your region. And then your physicians, when they're hired by your organization, they're expected to do telehealth. We actually have two different scenarios right here in Billings, Montana. One of the organizations here is a fully integrated healthcare system, where the CEO of the hospital basically said, we will integrate telehealth into our outreach services. The other one, the physicians are not employed. Not all of the physicians are employed by that organization. So it makes it a little bit more difficult for you to dictate to an independent physician that telemedicine will become a part of his practice. And so it's not that you can't do it, it's just that you have to take a look at a different way to integrate with that group. I agree with Lloyd in that you need to make sure that you have the IT staff involved in your advisory group, if you will. And I would recommend, if you're just getting started in telemedicine, to put together an advisory group that meets on a regular basis, that includes leadership within your medical practices. So you're a chief medical officer, or a physician who is a physician champion, who's either used telemedicine or is very interested in using it. You know, if you can have someone who is a decision maker in your organization on that committee, and your IT staff. Because Lloyd is absolutely right. A lot of times IT gets left behind, and people start moving forward in establishing a telemedicine program, and then IT is brought on board after the fact, and it becomes very hard then you have a lot of challenges with trying to make sure that that telemedicine program is integrated into your organization, and that the security issues are dealt with in a timely manner, and that you don't end up with problems associated with that. So another problem then, or I don't know if it's a problem, but a challenge, is when you have an existing telemedicine network, or when you're deciding your network, what kind of a network is it going to be? Are you going to have a network that's a hardware-based network, or are you going to have a software-based network, or are you going to have a hybrid of both? Older networks tend to already have a lot of hardware out in the field. So practitioner carts that have like a Polycom or Tanbird, Cisco, all of those systems that are already deployed out into the rural communities. And then you decide that you're going to implement a software-based program like video or Zoom. How do you integrate those two systems together? You know, or is that something that you're even wanting to do? If you start with a software-based program, and that's an internet-based program, then you need to make sure that you have the internet capacity in your rural community, so that your call isn't dropping at noon or at 3:30 in the afternoon when all the kids get home from school and they're all getting on the internet. We've seen some of those issues when we've deployed software-based solutions out into our rural communities. So what we've actually done is, when we deployed an emergency room system, is we made sure that it was a software-based system, but we made sure that we had a dedicated line to that system, so that we weren't dealing with degradation of our video and audio at certain times of the day when the internet was being used more in the community. So, and then training your people to use equipment, that's really important too. And not just one-time training and then we'll see you maybe 6 months again from now or 9 months from now, but constant training with your staff out in the rural community. Even if you don't actually, not just the staff out in the rural community, but your physicians at your urban facility as well. You know, we tend to forget stuff. What do they say? You retain about 10% of what you're taught. And so if I go out and I train you and then I leave and you don't use the system for a month, you've lost a lot of what I've already trained you on. So it's real important for those of you who are establishing the network to have constant training, connecting with your people out in the field, making sure the system is working well, making sure that everyone feels real comfortable with using the technology. because if they don't feel comfortable and the first time they try to use it and they get frustrated, you're going to have a really difficult time getting those people back to using the system again. Another thing that's real important is to build those relationships out in the field. Make sure that people actually want the services that you're preparing to provide. We've had opportunities where we put equipment out in the field, and then we thought, well, if we build it, they will come. And then we found out they really didn't want a telemedicine solution in their community at that point in time. Now, that was before we had a parity law in the state of Montana. And as Mario suggested, once you have a parity law, that really helps a lot with the reimbursement of telemedicine encounters. And we've seen a real climb in the use of telemedicine in the state of Montana since we did pass a parity law, and our third-party payers are all paying for that service. So you also need to find out, what your state does with regards to reimbursement. Clinical champions are extremely important for once again, for the development of your telemedicine program. Because what I have found is I can talk with leadership in the rural hospitals all day long. But when I connected my doctors to the doctors, that's when telehealth really took off. And so it's real important to have your clinical leadership on board, to have your clinicians selling it for you, and then it's really going to help you go really far in developing a program.
Mm-hmm. And I think that's a really great transition to bring Sarah in. Since Sarah, you have the clinical lens, would love to get your thoughts on this question.
Yes, I totally agree with what Doris was saying about clinical champions and them being essential. You want a clinical champion at your larger site as well as the remote sites. And that leads back to the clinical training that Doris was talking about. So each one of, for example, a telestroke site, you need a clinical nurse champion or someone that's actually going to be there on site to help facilitate the training. But before you're beginning a program, as what Doris was talking about, administration buy-in, you also need that lead clinician at your site or over the whole program to help guide and just really get people energized about it. Some champions are let's start tomorrow and get this done and implemented, and they're so gung-ho, whereas other clinical champions, you need to kind of nudge them along and hold their hand a little bit, and then they can be your biggest champion after you sort of orient them to telemedicine and telehealth. And most clinicians are very passionate about their patient care, and so if you can just say, you can still develop a relationship with your patients, you can provide excellent care through telehealth if done correctly and with the right integration. And I think once you show them those things, they will be your clinical champion. So they can either be cultivated or they may just come to you seeking out your help.
And Becky, I'd love to turn the microphone over to you if you have anything to add to this question.
I totally agree with what Sarah and Doris have said. It's so important to get the doctors involved. And, it kind of tags back to what Donna had said earlier. As not being clinicians, and I include myself in that bucket, I can play with a piece of technology all day long. But until a clinician that uses it on a daily basis picks it up and says, oh, wait a minute, I hold my stethoscope this way, or, whatever it is. Working with your doctors is so important. Their buy-in. Without their buy-in, the program's not going to go.
So I see Courtney sent an essential question for operations. She asked, in point-to-point video, what should be listed as a place of service for your claim? Is it the patient location or the physician location?
Mm-hmm. Yeah, and so when you're billing telehealth, and I've got some slides here I'll share in just a moment, just to some resources. When you're billing telehealth, the 2 points are generally going to bill separately. So the patient location is, if it's Medicare or Medicaid, is going to bill that facility code, that Q3014 we spoke about earlier. And then the provider at the hub, or the provider at the hub or the distant location, the patient is at the originating location, is going to bill for their services just as if they would if they're in the office. I'd like to lean on some of my other specialists here on the call, my other panelists. I've actually seen it both ways, where they've billed it the place of service as the patient and the place of service as the provider.
And it really depends, this is Doris, Becky, it really depends on what kind of a relationship you've established with that rural site. For example, if you have a consulting agreement with the rural facility or the originating site, then they may be the ones that are actually doing all the billing for the services. So, but as far as the reimbursement determination is, the originating site is always where the patient is.
And that should be the place of service on the submission.
That's correct.
And then just to add to that, I know in our region, for the current New York Medicaid program, they do have some requirements. If you're part of the same health system, they actually want the patient location to be billing for everything. So there'll be some specifics depending on the payer. Another question that came in, I think related to this operational question, was a provider wanted to see a patient from their home. And I'd love to welcome comments on this issue of connecting the patient at home. And I think this really includes a lot of the different aspects we've already talked about.
I'll discuss that one. It depends on the specialty and the provider, especially if they're on call or at night. I know with our ER-based programs where you may only have 4 specialists in a state, they are going to have to see patients from home or from wherever they're at on an on-call type setting. So, and that's all into the workflow integration. So they may see them from a hardwired computer, an iPad using secure software, or other types. But I'll have you all discuss the billing questions related to that.
And then I think in addition to the provider being at home, what about if the patient is at home? Can we connect to the patient at home? What are some of those challenges that are faced? And I welcome Donna and Lloyd and Mario to chime in here too, because I think technology and policy may also play a role in being able to connect to the patient when the patient's at home.
Mm-hmm.
Well, I mean, I think there's no doubt. I mean, what we're seeing really over the last, I don't know, I guess a couple of years, especially as home monitoring really has ramped up. But, you know, those of us in the telemedicine world, I mean, we labeled it as direct to consumer. And you're seeing those direct to consumer models that are popping up. And, you know, I think there's still a lot of kind of feeling that out. There's still a lot of states that are trying to, and Mario can really discuss this, you know, further if he wants to. There's still a lot of states that are still trying to address that from a, you know, from a legality standpoint. There's, you know, I mean, when you start going into the home, you know, you're dealing with, you know, it's just a different animal, bandwidth requirements, making sure that, you know, that they have the bandwidth at home to be able to do that. Of course, different types of devices, whether you're using a cell phone, a tablet, as, you know, Sarah, Dr. Rhodes mentioned a while ago, or whether you're using your home's personal computer. I think the thing for me that I always touch on, it just goes back to quality, making sure that, you know, that physician's able to get, you know, a quality exam to be able to see what the patient needs to see. And then, of course, the history. That's one of the things that so many of the medical boards are dealing with now, is making sure that when you talk to that doctor on the phone, that physician, I know Georgia has a law where it says, that the physician, has to be able to do a physical, and the physician has to be able to, do a full exam, in other words, and has to be able to do have a history on the patient. And so Georgia is one of the states that actually does require an in-person visit as well once a year. So, there's a lot of things that come along with that as well. So I'll let some of the others talk a little bit about that as well.
I'd like to just add a little bit. Oh, is that you, Mario? If that's you, I'll defer to you, and then I'll go after you.
I was just going to talk about the specifically, you need to look at what your laws are in your particular state. The majority of the states don't require an in-person examination before using telehealth, but some do. And in the case of Texas, we now have a federal lawsuit on behalf of Teladoc that is challenging that component from their medical board. I think ultimately it goes back to what I said earlier. HIPAA laws comply whether it's in person or done virtually. And I think the real benefit and the value of telehealth that has really been the key to the whole notion of putting the consumer, the patient, at the center of the healthcare system and allowing for greater communication, support, and assistance to be able to allow that to not necessarily have to always physically go in for an examination, but or for a visit where it can be done virtually from the home, from the workplace, or wherever the patient may be. I think this is where the field is going. As Lloyd mentioned earlier, one of the real obstacles to the seamless approach to using direct-to-consumer is the lack of interoperability. And I think one of the concerns from the medical profession is, particularly around chronic disease management, is that if the convenience of using a direct-to-consumer, whether it's a Teladoc or a CVS, is to what extent is that integrated into the treatment plan of your medical home? And so in many cases, this convenience could actually result in some real problems if there's not communication between the providers and your provider does not know what you've done in off hours using this convenience.
Mm-hmm.
And that's exactly where I was going to go, Mario, is that direct to consumer and where is the data being stored. And so if you do have the other thing that we're starting to see really a movement toward is with the accountable care organizations, that organizations, healthcare centers are actually looking at some kind of virtual healthcare direct to consumer as part of their chronic disease management system. And so Mario's absolutely correct. We are moving there. What that's going to look like in a few years is going to be interesting. I think we're going all the way over to the far side like we always do when we jump into the newest and greatest thing, and then we're going to start moving a little bit back towards the middle as we start to determine whether or not this is the best quality of healthcare that they can actually get. Is this a continuity of care? How are we ensuring that we know what kinds of services that patient is getting and who is providing those services, especially when we're dealing with a chronic care model? So it's an interesting field to be in. Some organizations are jumping into it head first. Some organizations are sitting back and watching to kind of figure out what the landmines are before they get into it. But it is not going to go away. It will be a part of the future of our healthcare system.
Yeah, I just wanted to jump in. And from a reimbursement standpoint, Medicare every year puts out a telehealth fact sheet. It's about 6 pages long, and it's got the list of the different codes that they will reimburse for. And based on those codes, and there's specific originating sites that they will pay for. Home is not an eligible originating site. Most Medicaid programs follow that and have a similar listing of originating sites that are eligible for payment. Right. We did get one question here that I wanted to address. While talking with the patient at home, the security and privacy concerns seem overwhelming and maybe not practical. And, as we've been discussing, it really depends on the situation. There's so many variables. But companies like Teladoc and American Well and even Walgreens, all kinds of organizations are coming up with virtual platforms, and they're not going to go away. So we're going to have to go through these, figure out the legalities of all of this and the HIPAA concerns, and maybe, right now most of the virtual platforms the patient pays out of pocket. It's not reimbursed by any insurance company.
I just want to add that I think direct-to-consumer has its place. I much prefer as a provider for my patient to go in my healthcare system to get that care if possible. As Doris said, not all healthcare systems are integrating that at this time, but as with any visit, if you need to make a referral, you need to be able to send someone for an inpatient visit after a virtual visit if needed, if they need specific labs, biopsies, additional testing. For sure, a follow-up needs to be done with a primary care provider or someone that is in the area that the patient resides. So I think that's important. And I will say some mHealth equipment where we send patients home with a blood pressure cuff scale, pulse oximeter, all of these can connect to a software portal. This may be being managed by a nurse or a nurse management company. A lot of those portals have two-way audio and video, and it's sort of a part of the package as a whole. And so it's not so much reimbursement for that type of monitoring.
And direct to the question, I think the issue of training for the provider is really critical. Knowing that the provider, when they're doing a telehealth visit, that there's certain standards and guidelines that need to be followed to ensure for privacy and security of that patient's dialogue. And so where it's being done, how it's being done, what equipment's being used, what kind of software, all of that are components of direct-to-consumer or virtual care, whether it's through a portal or directly.
So there's no question that direct-to-consumer is really getting a lot of attention right now. I've noticed it seems like people will reach out, and if they've heard about direct-to-consumer, that's really all they know about for telehealth, and they're not familiar with sort of the traditional hub-and-spoke model and everything else that's happened for 20-plus years. Maybe a tough question, but for anybody who's interested in answering, do you see the direct-to-consumer movement, is that sort of the pinnacle of telehealth? Is that the future? Is that where we're headed? Or what might the future look like?
I think it's part of the future. I think that it'll be one of the pieces of the technology that is used to provide healthcare services to our patients. When you look back through history, you have right now we have where people are able to look onto their medical records. So that's part of a direct-to-consumer healthcare service actually being provided by healthcare entities. But, at one point, a fax machine was a huge deal, and now nobody uses faxes anymore. At one point, radiology was done with films, and now it's done over PACS systems, and we send it all over the place. So I think that direct-to-consumer healthcare is going to definitely be a part of how we provide services. I don't think it's going to totally replace all of the types of telehealth that we do today, but I think it has a couple of really good types of services that it works well with. One of them is that primary care need that is not. It's a very minor issue, and people are doing that now with a dial-a-doc type of system if you've got a cold or a rash or something like that. The other one is with chronic care management, and I think that's where we're really going to see a lot of the movement, especially with organizations that serve extremely rural populations or populations that have a real transportation barrier to getting to the hospital and being able to, or the clinic, and being able to see their physician in a regular manner. Once again, though, what we're really going to have to start doing is dealing with the data that this direct-to-consumer healthcare service provides. Because does a doctor want to see that your A1Cs are within the range every single day of the week, because that information is getting transported back to the doc. So what we're going to end up with is a huge overload of data, much of which, where does that data go now? If you're generating that data and you're sending that data back to your healthcare provider, is it important to put that data into your medical record? And so then if that is in truth the case, then we're going to have to take a look at storage capacity and all those kinds of things. Or do we just want the data to go into your record when you're alerting outside of those normal parameters? And so, you know, we have to be real careful when we do implement direct-to-consumer healthcare. We implemented a program with diabetes patients several years ago. We were gathering data on the patients every day. And the doctor said, I don't want that information. That's way too much stuff. I don't have the time to be looking at this information every day. All I want to know is if that patient, if they're alerting outside of the norm. I don't want to see all of this regular day-to-day stuff. So I think, you know, definitely it's part of the future, but I do think that we need to think through some of the things that we're going to create for our physicians, because it, once again, if it creates more work for the doctor, then it's not gonna fly.
I would say it's more than just a direct-to-consumer in terms of the, is this the pinnacle? Definitely the consumer at the center of the health system and the medical home, where care is integrated across the board, from nutrition care to social services, et cetera. And so we're seeing more and more of health systems that are value-based, such as the Kaiser Permanente system, going full bore into using all forms of technology for communicating with their patients. The movement is going more toward individualized care, patient by patient, and being able to enhance the communication through patient portals to ensure that it's also not physician-centered. I think that's the key here, is that now the physician is part of a larger team. And so that doc doesn't necessarily need to see all the data. There are now the capacity of doing informatics and assessing according to certain algorithms, patient by patient, no matter how much information is being sent. The key is what's actionable and how do we make this work so that the care of the patient is done in a way that the technology is there as a benefit, not as a slave.
Andrew, I think you're muted.
Can you hear me now?
Yeah.
So we've gone 1 minute over our time. I don't want to keep our panelists too much longer. Tiffany submitted a really great question. I'd love to try and address very quickly, but I don't think we can address the whole scope, but we'd love to open it up if anybody would like to comment. She mentioned some of the peripherals that are being developed, the thermometers, the electronic otoscopes, electronic stethoscopes, specific for the patient at home, and whether or not we can rely on untrained patients to use those devices. And would love to open it up if anyone would like to comment, last comments on that question before we end.
Well, I think the things like thermometers and pulse oximeters are simple enough that anyone can use them with a little bit of training. I think it's a good idea to have people involved in their own healthcare and become aware of what their body is doing. I don't think that's an insurmountable obstacle, really, when you're talking about a blood pressure cuff, or especially how things are automated. You may not trust a patient to write down the blood pressure numbers correctly every time things get transposed, but if the signal is sent to a base, which is sent to the cloud, or it's stored on a device, the margin for error is reducing greatly as these devices are becoming more sophisticated.
I think one of the other things that you need to think about when you are sending equipment home with patients is making sure it's the right size blood pressure cuff. I know with the projects that we have here, we have fluffy people in Arkansas. So with that, not every mHealth device has an appropriate blood pressure cuff to send home with the patient. And some of our patients were not able to be in the program because we did not have a blood pressure cuff that would fit them.
And the technology is moving very rapidly now. There are now biometric sensors that are the size of a quarter. That's done passively. The patient, the consumer doesn't necessarily need to do anything except ensure that there is a Bluetooth connection. And so more and more of this is the field of biotechnology is at such a point now that it is oriented toward usability by the consumer. Whether they're an LD consumer, whether it's a different language, whatever it may be, the field is moving in that direction to make it available.
Well, and I think the thing to consider too, we do demonstrations all the time, and I know Donna and them can speak on this with equipment, and like using a stethoscope. Well, how are you going to get a very good lung sound? You're going to be very limited, I think, in some of the things you're going to be able to do from home. But at the end of the day, Mario just mentioned, as technology is rapidly changing and advancing, it's not going to be perfect, but the consumer's driving it, and I think that's where we are just headed, where you have, you can get in your car and your car seat can monitor your vital signs. It's just where we're going. So. And more and more devices are becoming smaller and making it more, giving the consumer the ability to be able to do certain things like look at an eardrum, or look at a nasal passage, to where a doctor can kind of make a quick diagnosis. I think right now the thing to keep in mind, though, is still a lot of people, even though they may talk on the phone or they may see a doctor from home, a lot of times they're still ending up in the primary care physician's office. And so it's still not a perfect thing, but healthcare systems are realizing that, hey, if I can head something off and maybe catch something a little bit earlier, it's going to cost me a whole lot less than if we wait and they end up in the emergency room or whatever. So.
There's one other question, Andrew, that I did want to ask Mario about. The question was about a transmission fee. It's T1014. Medicare doesn't pay for it, but I think they're talking about California Medicaid. Are you familiar with this code?
Not specifically, but I think that would be the way a transmission fee would be paid. Specific codes that are developed at the Medicaid state level for those payments.
Do you know if
you could send this, I could respond offline to that
Sure.
question.
So I think that's it for our webinar. Becky, I don't know if you want to bring up the...
My team here says, yes, that is the specific code for California for the transmission fee. So,
okay, so the question on that transmission fee is, can it be charged if the distance site provider is at home and not in clinic?
It's usually charged by originating site.
So yeah, it's done by the originating site.
Okay.
Could it be, could the home be an originating site? I think we'd have to look into that.
Or no, this is it.
Well, we'll follow up
Okay,
directly.
their contact information. We'll put you guys in touch.
Thanks.
Okay. Let me write that down real quick, and then I'll bring up our closing slides.
While you do that, Becky, I just want to thank everybody for joining us, and thanks to the panel for your time and expertise.
So our National Telehealth Webinar Series that you're attending today, it does occur every month. And next, it's always on the third Thursday of every month. Next, oops, I'm sorry, I forgot. The The South Central Telehealth Resource Center will be providing the webinar next month. They are still in the midst of discussions with the provider of that. So you'll have to wait and see. We'll send out an email when that topic is decided upon so you can register for that session. And we also will be sending out an email. We'll post today's webinar on the Telehealth Resource Center YouTube page, and I'll send out an email with the link on that once we get it up. And there is a SurveyMonkey. We'll put this link in our email to you as well so that you can provide feedback on today's session.
All right, well, thank you again, everybody, and thanks for all the participants for joining us for this sort of experimental webinar version, and we certainly would love your feedback on what you thought of this, and if this is something that we should try and do again and bring on more experts and have this discussion and open Q&A.
All right, thanks, everyone.
Have a good day.
Thanks.
Bye.
Bye.
And Elizabeth, if you're still with us, I see your question. Where can I get more information for Florida? Would certainly welcome you to reach out to the South Central Telehealth Resource Center, and Lloyd has just jumped off. But you can find all Southeast Telehealth Resource Center. No, thank you, Becky. You can find all of us at telehealthresourcecenters.org. And you can find your appropriate regional telehealth resource center, or certainly reach out to the national policy and technology centers as well.